Welcome to this education session on exploring surgical options for advanced colorectal cancer. I shall introduce you our fantastic speakers this afternoon. Thank you both so much for joining us and for agreeing to do this. So, Mr. Alex Tzivanakis, I'm going to say it wrong. Pronounce your own.
Fine. Alex Tzivanakis.
Tzivanakis, who's a consultant surgeon from the Peritoneal Malignancy Institute in Basingstoke. So Alex qualified in 2005 after completing his medical degree at Imperial College London, then completed his surgical training in Oxford and Wessex Deaneries after completing his research degree in 2014. He joined the fantastic Peritoneal Malignancy Institute in Basingstoke in 2017 as a consultant surgeon. He's published extensively and presented his work on peritoneal surface oncology. And he's joined, I'm delighted, by Vicki Evans, who's the lead peritoneal malignancy clinical nurse specialist at the Institute. Vicki studied at Southampton University and qualified in 2003, completing a BSc and Masters in Advanced Nursing Practice after qualification. She's been with the peritoneal malignancy team since 2007, as the second clinical nurse specialist for the service, and she now leads a team of 5 specialist nurses, and I'm sure is very busy, supporting patients throughout their treatment pathway, and her practice is focused on a personalisation of patient care.
Through cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, also known as HIPEC, specifically for colorectal cancer metastasis. We also treat pseudomyxoma and appendix tumors and peritoneal mesothelioma here in Basingstoke, but we don't treat ovarian cancers. So first we'll go through a little bit about the background of colorectal peritoneal metastasis, the principles of operation, a little bit about evidence and outcomes, and then Vicki and I together will go through challenges that the patients are facing and challenges that services are facing, both the end users, i.e. the hospitals referring to us, as well as us, around these processes of the way they work in the UK. So first of all, there are 5 centres that treat colorectal peritoneal metastasis in the UK, and the majority of patients are treated in Basingstoke and in Manchester at the Christie. Birmingham is doing, I think, about between 50 to 100 cases a year, and they're increasing the numbers quite steadily. Dublin is the only centre in the Republic of Ireland, and Dundee up in Scotland is doing a few. Now, how big a problem is peritoneal metastasis in colorectal cancer? It's probably the 3rd most common area of metastasis in the body. The numbers vary a lot depending on which series you read. However, the range is between 10 and 15% of all patients with colorectal cancer will have peritoneal disease, and probably about 25% will have more than one site, including the peritoneum. So we generally tend to focus on the patients with peritoneal disease being the single site of metastasis. So evidence. So it's not one day we decided we're going to have a go at this. There's been a kind of evolution of evidence and how the services have came to what they are now. So there are some animal models, systemic reviews, some randomized control trials, but not many. And then got formally clinically commissioned by NHS England. And then NICE guidelines with the latest update in 2021 are supporting, and we'll go a little bit about the recent randomized trials. So very quickly, there's several animal models that basically have created most of the times mice, and they tried various regimes of HIPEC, and it shows that if you give HIPEC in a mouse, it makes it better from a peritoneal colorectal metastasis point of view. Then moving forward to the more kind of series, there was a couple of systemic reviews who've looked at comparing CRS and HIPEC against systemic chemotherapy, and showed much bigger improvement in survival rates in the surgical arms compared to just systemic chemotherapy, with a caveat that these reviews were all quite now out of date, in that systemic chemotherapy has improved in a very big positive way since these reviews were published and looked at. Then there are some very big series. This particular one is from France, where they looked at overall outcomes of patients, obviously very specifically carefully selected patients to have CRS and HIPEC over a 20-year period. And see, there's 500 odd patients, 23 centers in France, and you can see that these patients do get a good overall survival. You have to remember at that point, the alternative systemic chemotherapy will only give you a survival of about 6 months to a year maximum. And then this is the kind of the first and biggest randomized controlled trial comparing systemic chemotherapy with CRS and HIPEC. There are some limitations to it, in that unfortunately some of the appendix cancers were also included in the data, which made the data not as pure. However, you can see almost a doubling of a 2-year survival with surgery, which then led to NICE and NHS England to commission it back in 2012. Then there was an update on 2021, mostly as a response to a trial, which I'll talk to you a bit later, just in a few slides time, that said that basically this should be offered to the patients in the UK and in England. And in the latest update from NICE, is 3 years old now. However, patients who present with peritoneal metastases in the MDTs should be offered systemic anti-cancer treatment after discussion in an MDT, and then referred to one of the peritoneal centers for consideration of CRS and HIPEC. So what do we know so far? So case selection is vital. I can't really stress that enough. Unfortunately, we can't operate on everyone, and honestly, we shouldn't operate on everyone, because we actually can do more harm than good. So we have learned over the last 20 years that we need to select our patients well. And when I show your data, I'll explain how that translates on better outcomes. So the way we select our patients, we use this peritoneal cancer index, which is basically a way of describe. So this is designed for surgery. However, we apply that to radiology, and we divide the abdomen into these 9 areas. You can see there on the left on the diaphragm, on the diagram, and then you score from 0 to 3, depending on the biggest nodule you can see. If there is confluent nodules, then it goes to 3. You're not supposed to score the primary tumor if a primary tumor is there. And then you divide the small bowel into 4 artificial regions. The first basically quarter of the abdomen of the small bowel, then so upper jejunum, lower jejunum, upper ileum, terminal, and lower ileum, and then you give a score. And in general, anyone below 20 probably potentially can benefit from CRS and HIPEC. If you have more than 20, you have too widespread disease, and probably that number of 20 is quite generous. We now realizing that probably you're looking more at the 15 region. and the reason why we're interested into this index is that we want to predict whether we'll be able to remove all the disease. If we can remove all the disease, which is what we call the complete reduction, means that we hope that we will not leave any cells behind. But obviously, we're only removing clusters of cells that we can see. We cannot see single cells. So to give you an idea of the numbers, a score of 1 is tumors size of up to the size of the eraser at the back of a pencil, which is about 5 millimeters, and anything between 5 millimeters to up to 5 centimeters, which is a golf ball, then that's a 2, and anything more than that, it's a 3. But remember, if you have even small little dots of 1 millimeter that are touching each other, then you go straight to 3. And these are some examples. Go have the next slide. These are some examples of what it looks like in real life. So this on the left-hand side, you can see the yellowish pink tissue, which is the omentum, and you can see the white big lumps, which is the disease, and then you can see at the bottom the transverse colon. And on the left picture, you can see small bowel mesenteric disease, which generally is a worse prognostic factor. So once the small bowel is involved, things start getting less good for the patient, because we can't really afford to lose much small bowel, and therefore it limits our ability to achieve complete reduction. So the next one is an example of a confluent disease. This is a peritoneum on the right-hand side of the abdomen that's been stripped, and obviously it's been pulled up, and you can barely see, just see below the bottom finger there's a bit of liver surface, which also has disease on it. So this patient has too widespread disease to actually benefit from surgery. So these are the kind of a couple of case series from Europe, which shows that the importance of having complete reduction. So you can see that the survival curves in patients with complete reduction, which is on the right-hand side, and the yellow line is higher than the other two, which means that we're leaving even a few millimeters worth of disease in colorectal metastasis has a detrimental effect. And then on the left-hand side, you can see that the lower the PCI, the better your survival, which kind of makes sense. So what do we mean by complete reduction? So CC0 means that you cannot even see a single dot of disease. CC1, it means that the disease is less than 2.5 millimeters. So that's the width of a 2-pound coin. And CC3 is if it's more than 2.5 centimeters, which is the diameter of a 10p coin. So this operation was kind of pioneered by Paul Sugarbaker from America in Washington, and he started doing these operations in the late 80s and early 90s. And we were lucky that Brendan Moran, who is our senior surgeon here, who is unfortunately coming to retirement, but we're hoping to try and convince him to stay a bit longer. Met him back in the 90s and then invited him to come and help him with a pseudomyxoma patient. Then that led to Basingstoke becoming a pseudomyxoma treatment center, and that service was commissioned in 2000. And then the unit developed, more consultants were appointed, more specialists were appointed, dietitians, pharmacists, and then the team now has grown from 1 surgeon to 6 surgeons now. I had a locum appointment a month ago. 5 CNSs, 3 dietitians,
lots of admin support, research
6 or 7 secretaries, a whole research department. So basically we now have a unit of about 50, 60, 6 radiologists, specialist radiologists, anesthetists, ITU team. I mean, I can talk about the team for a very long time. So what is actually involved in the operation? It's basically multivisceral resections, and in the temptation is to remove just the lump, but we tend to remove the area where the lump sits. If you have a lump in the omentum, we'll take the whole omentum. We don't just take the lump and a little bit of omentum around it. If you have disease affecting your right side of your peritoneum, we'll remove the whole of the right side, not just the lump and a little bit of normal peritoneum. And the idea is that you're maximizing the amount of cells that you remove without that you not be able to see. And usually for the CPM patients, we don't remove many organs, but we can. And in women, we will always recommend removing the ovaries, because the ovaries provide a very attractive environment for these cells, and is very common site of metastasis that give rise to the well-described Krickenberg tumors, which is basically an ovarian tumor that has come from a cell that has not originated in the ovary. So in a woman, most women will have a combination of peritonectomies, always the ovaries, of course, after the consent, and most of the time the hysterectomy as well, and include the pelvic peritoneum. And then we will resect any part of the bowel that need to be resected, and then reconstruct anything that can be reconstructed. Generally, if we are finding ourselves operating in the four corners of the abdomen, it means that we haven't selected the patient correctly for colorectal metastasis. So next slide, please. So this is kind of what a few of the peritonectomies look like. On the top left, it's the diaphragm, and you can see the liver at the bottom, and the arrows point at where the disease areas are. The one next to it on the right is basically the peritoneum from the abdominal wall, same as the bottom left. And then the middle bottom picture is when we do a liver capsulectomy, which we shouldn't really be doing for colorectal metastasis. So this is more for information. This is more commonly seen in pseudomyxoma. And the last picture is what the pelvis looks like once you remove the peritoneum, the uterus, and ovaries in a woman. So you can see the bladder being lifted up, and the stitch area is a vagina that's been closed, and the rectum is at the back and pushed down. So once we remove all the tissues that needs to be removed, we will give the chemotherapy wash. And next slide, please. And this is kind of what it looks like. So everyone is focusing on HIPEC. HIPEC is only the icing on the cake, and I'll talk about that in a moment. It's actually literally a bath. It's a hot chemotherapy solution. In our unit, we use 10 milligrams per square meter, which is probably the lowest dose in the world. And we give it for 1 hour, and we heat so you see those 4 tubes at the bottom of the picture. Basically, 2 of them deliver fluid, and 2 of them take the fluid back to the machine to take it into a thermal exchange mechanism to maintain the temperature steady at around 40 to 42 degrees. And the idea is that the chemotherapy agent will kill some of the cells that might not be attached to any. They'll be basically free floating. There shouldn't be any attached cells, since we should have achieved complete reduction. And the heat adds another cytotoxic benefit to the process. So, in summary, the ideal patients, we'll go to the next slide, should have low volume disease, i.e., ideally in 1 or 2 areas of those 9 areas we talked about earlier. Ideally, the peritoneal disease will appear a year or so after, at least a year or so after the first primary tumor was removed. And ideally, we'd like them to have some response to systemic anti-cancer treatment, i.e., that these nodules don't grow or they get smaller, and especially no new disease appears. And generally, patients with systemic metastasis and peritoneal disease do much worse than obviously patients without. The reason for this criteria is that once you get peritoneal disease, you have systemic disease. It's not you should not think of it as a local regional recurrence. This is it's a systemic process. The original theory was that the peritoneal metastases were from spillage of cells directly into the tummy, but there is now emerging evidence that this is more likely to be through the blood. And we know that the cells that make these metastases are very different, say, for example, than liver metastases. Liver metastases seem to have more monoclonal, i.e. most cells are similar, while in peritoneal disease, they seem to be polyclonal, so they seem to be different types of cancer cells within the same nodule, which makes peritoneal, which may be one of the reasons why peritoneal disease doesn't respond to systemic treatment so well. So I've talked to you about the HIPEC being the icing on the cake, and that the majority of the benefit that the patients see on all the kind of the data that is published is seen from the removal of the tissues rather than the HIPEC itself. Patients hear about this operation and they think HIPEC is the magic potion, but HIPEC is not the magic potion. It's probably the most crucial take-home message is that HIPEC has a role and it definitely benefits patients, but we're not sure what that role is, and we know it affects. It probably is forcing us to do good surgery. So now that brings us to the more controversial part of the talk. So there was a very well intended clinical trial designed by the French called Prodigy 7 that was concluded and published in 2018, and then it wasn't published for another 3 years because it created a lot of controversy, which I'll try and go through now. Then there's a couple more trials I'll very quickly go through to give you a little bit of evidence background. So Prodigy 7, it's basically a randomized trial. It's an open label phase 3 trial. It's multi-center. It was designed to go have the next slide. It was designed, basically was comparing CRS and HIPEC, so basically complete reduction with or without HIPEC, and trying to see whether HIPEC had a role. Now they were aiming to show that adding an hour of HIPEC will give you 18 months survival benefit, which even the authors of the study now realized that was too optimistic. So the brief design of the study was basically you had a patient who was deemed resectable, then was randomized to have HIPEC with oxaliplatin, so CRS and HIPEC. So CRS, and then if you're randomized to have HIPEC, you added HIPEC at the time, and then if you didn't have HIPEC, and then you had systemic chemotherapy afterwards. However, patients could opt to have HIPEC if they were randomized to the no HIPEC group, and there was a good proportion of patients that took that option. And then all patients had 6 months of systemic chemotherapy. The primary endpoint was overall survival, which was, and I'll explain to you, was probably a little bit optimistic. So they showed that the median survival for both groups was about around 42 months, and there was no benefit overall survival with a HIPEC. So giving HIPEC didn't seem to make any difference. And they showed that the morbidity with oxaliplatin HIPEC was higher. So patients who had the HIPEC had more complications. So obviously you can imagine that caused a lot of controversy. So obviously we now had a lot of time to kind of dissect the trial, and a lot of discussions have happened in several conferences and around the world. And generally this is kind of what the consensus is that this trial showed that good surgery works. We're achieving a median survival of 42 months in patients with advanced cancer, which is a very good result. Good surgery has a role to play and is a key kind of weapon in our arsenal of managing these advanced cancer patients. And you cannot isolate surgery or isolate chemotherapy. You should have them together and working together to achieve the better outcome from the patient. Even though there was no difference, 15% of the patients in the trial were actually cured of cancer and they had no further recurrence. And there was a subgroup of patients that seemed that benefited from HIPEC. So what was the problems with it? Obviously, it was powered at a very optimistic survival benefit. Also, we were looking at whether a local regional treatment will have a systemic effect, because you're giving a little bit of chemotherapy, a one-off dose of chemotherapy on the surface of the tissues, expecting to affect just the sort of overall survival, which everyone feels this is unrealistic. A peritoneal-free survival, i.e. whether the peritoneal recurrence would have been a more better primary endpoint. The other thing is, we know already that only a majority of patients will be cured by CRS and HIPEC, and really the overall survival is depending on response to the systemic anti-cancer treatment, and CRS and HIPEC is an adjunct to that. And the majority of patients already were exposed to oxaliplatin before they had the CRS and HIPEC. Therefore, their cells and tumors were already exposed to this drug, and there's a good evidence and published that shows that this is true, and cells do get chemosensitization. Oxaliplatin HIPEC, we know, and it's been published several times in the last few years, that if you compare it to mitomycin, which is what most UK centers use, has much more high side effect profile. And then remember, I told you that the patients had the option of going to HIPEC if they were randomized to not have HIPEC, and 12% of them took that option, which kind of shows that patients have voted on with their feet. So how did that affect the wider community? So the peritoneal surface oncology group, which is kind of the world society of centers and people interested in peritoneal surface malignancy around the world kind of follow. There was a survey around the world, and 19 experts from 19 countries were involved. Basically, it is a survey. It's not a very high-level evidence. However, it showed that the majority of centers moved from oxaliplatin to mitomycin. In our center, we experimented with mitomycin back in 2016, and we used it in 20 patients, and we had very high bleeding rates, so we stopped pretty quickly, and we stuck to what we have been using before, as our results were good. There was some reduction in referrals in some countries, and in 2 countries, it was completely removed. HIPEC was removed from the national guidelines, and I think that was Germany and America. So the kind of the consensus of the experts was that the cornerstone of treating patients with peritoneal metastasis is good surgery. And at the moment, there's not enough evidence to stop using HIPEC. And then we know that, as I told you earlier, that if you expose tissues to oxaliplatin, you get less good response compared to mitomycin, especially if the tissues have been exposed to oxaliplatin before. And then there's a lot of work going on at the moment between the various centers around the world on standardize what HIPEC regimes we're using, i.e. we know that HIPEC with oxaliplatin, for example, doesn't work. So we need to find out which does. Then I'll quickly go through this next couple of trials. Again, these were more, so both ColoPEC and the one in the trial afterward, they're both focusing on prophylaxis. So basically trying to prevent peritoneal metastases. And they focused on patients with T4 cancers or perforated cancers, i.e. the two most common risk factors for peritoneal malignancy, peritoneal metastasis from colon cancer. And one was done in France and one was done in Holland, in the Netherlands. And basically, they're very similar. They've identified these patients, and the idea was that they would do normal surgery and then give HIPEC either at the same time or within 10 days, but it could be delayed for up to 5 to 8 weeks, or not give HIPEC and then give chemotherapy and see, do a laparoscopy at 18 months. And the idea was that there should be 15% differences between the non-HIPEC and the HIPEC patients, expecting that about 25% will develop peritoneal metastases, and that if you give the chemotherapy, if you give the HIPEC, you should reduce your risk of metastasis by 60%. Again, quite optimistic. However, they saw no difference in peritoneal's recurrence-free survival, and they were pretty accurate in the prediction that there will be about 25% who will develop peritoneal metastases. So we'll have the next slide. So that basically trial confirmed that the T4 or perforated tumors give you a high risk of peritoneal relapse within 3 years. There was, by giving HIPEC and doing another operation, you delay patients having access to systemic chemotherapy, and whether that was a reason why they didn't do as well as they should have done. Also, laparoscopy is a pretty majorly invasive procedure with comes with risk, and therefore only 2/3 of the patients actually had the laparoscopy, so which makes the trial a little bit less valid. And we know that laparoscopy doesn't access all the areas of the abdomen, so the imaging is not as accurate. So you could have missed peritoneal disease. Sorry, next one. Sorry, one before. Yeah, that's fine. Okay, sorry. Next one, yeah. So Profilochiv was the French version, and basically they looked at the high-risk patients again. So either patients that presented with peritoneal metastases, had ovarian peritoneal metastases, or had perforated tumors, and they gave them adjuvant chemotherapy 6 months after the operations that they had, and then a year later they did a laparotomy. And most patients were given HIPEC, mostly oxaliplatin, unless they had neurotoxicity from their adjuvant oxaliplatin-containing regimes. They randomized 150 patients. Next slide, please. And then basically so if you were randomized to the experimental arm, you had the second look surgery with HIPEC. If you're not, you were just having normal CT-based surveillance. Next one. So what they showed was, there was no difference in disease-free survival if you had a second look laparotomy. However, half the patients that had the second look laparotomy had peritoneal disease that the CT scan had not picked up, which is quite concerning, which again highlights the limitations of imaging. So next slide. So what Profilochiv gave us was it confirmed that what we thought was high-risk groups, along with ColoPEC, are indeed high-risk groups. Also T4 cancers, perforation, obstruction, and obviously synchronous metastases. and he raised this issue that there's 50% of peritoneal disease as found a second look laparotomy when imaging is clearly not picking it up. And the criticisms in regard to the oxaliplatin-based regime is the same as we discussed earlier about Prodigy 7. The analysis was done as an intention to treat basis, and all patients were treated in peritoneal malignancy centers. So therefore, the patients that had the experimental arm probably had better not better, that's a bad word, but they had radiologists who were more used to looking at peritoneal disease, and also the patients that were on the non-experiment arm had access to have the systemic treatment much sooner than the patients that had the laparotomy, because obviously they had to recover from laparotomy. And finally, next trial, the HYPEC T4 trial is this. This was a trial done in Spain and published only this year. And again, it was looking at the T4 tumors without any obvious peritoneal disease at the time. The primary outcome was 3-year local regional control rate, and it was looking at also the disease-free survival and overall survival as a secondary outcome. They managed to randomize 184 patients, and the patients who had local regional control, i.e. no recurrence, in the HYPEC group was much higher, and it was significantly statistically significant compared to the non-HYPEC group. And there was no difference in disease-free survival and overall survival, which would, as we said earlier, we expect that CRS and HYPEC should really control the peritoneum rather than the whole of the systemic aspects of the disease. Next trial. So what this trial tells us is that, again, so this time HYPEC has a positive effect. As we kind of asked that those of us who treat and use this treatment know that HYPEC shouldn't have an effect on the disease-free survival and overall survival, and there was no extra morbidity as seen with the oxaliplatin regime. And again, the limitation of imaging will affect results. So we rely on radiology. So we rely on a radiologist saying that there is no cancer. So okay, next slide. So our data, which is not published yet, we're actually in the process of writing the manuscript. Basically, we looked at our data for the last 20 years, and we included 555 patients. The median age was about 59 years, well, exactly 59 years. Majority of patients were, well, just about majority of patients was women, 55%. And surprisingly, there was more right-sided tumors than left-sided. Rectums was only 9%, and the majority of the patients had metachronous, i.e. the peritoneal metastasis appeared after the primary was removed. And we've had, obviously, towards the last, the later years of that period, we had more molecular studies and mutation data available. Over the first few years, this wasn't available. 20% of our patients had previous systemic metastasis, and the majority of patients had some sort of chemotherapy treatment before. Interestingly, our PCI median is only 6, and when we looked at this data 4 years ago, it was up to, I think, 10. So obviously, as the years go by, we are choosing patients with lower and low volume of disease, as we are learning that the more disease you have, the less your outcome, the less good your outcomes are. So next slide, please. So the majority of the patients had CC0, and again, if I don't have the slide, but I can tell you that in the last 5 years, that number is even more close to 95%. And that's because we're getting better in predicting complicity reduction. CC1 is considered a complicity reduction in the definition of what a complicity reduction is, but I think for colorectal metastasis, it shouldn't, because even a few millimeters of disease will mean that the patients will do badly. And you can see the survival difference between the blue line and the green line. And that's only, so the patients with the green line have a couple of millimeters of disease left behind. And you can see the difference in survival. And obviously, if they have big lumps, of course, they don't do very well and they die pretty within a year. Next slide. So this is the overall survival, and you can see that our overall 5-year survival is now 63 months. Remember, in Prodigy 7, there were 42 months. And again, I think this is a result of choosing the right patients. The overall 5-year disease-free survival is 31%, which again, it's quite a positive outcome. And the patients who do get recurrence, the median time to recurrence is about 20 months. So if it's going to come back, it usually comes back in the first 2 years. Next slide, please. So what does that mean? This means that, unfortunately, biology is the king, selection is the queen, and technical maneuvers, i.e. the surgeons are the prince and the princess, well, surgeons and the team. This is not obviously my saying, this is a say by someone else. Recurrence is common. However, I think by selecting the right patients, we're giving them, we're extending their lives. With half our patients alive at 5 years, and actually curing around 20 to 30% of our patients. Risk factors for recurrence is nodal involvement, which means that they have systemic disease. Obviously, having systemic metastasis, which is why biology is important. And also, there's a lot of data now that if you have BRAF mutations, you're doing worse. And CC0, i.e. complicity reduction, is the heaviest and more strong predictor of survival, which is why selection is the queen. So what does that mean? It means that, I know I'm sounding like a broken record, but choosing the right patients is important. And the ideal patient is the one that has low volume. We're confident we remove it all. They've had a period of stability, i.e. the biology of the tumor is favorable, and then hopefully they will have a good operation, and then they will do well. I didn't put it there on the slides, but our mortality for this operation is less than 1%, and our major complication rate is around 9 to 10%. So HIPEC using oxaliplatin most likely it's not going to be it's not going to work, and as I said, most centers are now not using it. HIPEC has a role to play as an engine to the good operation and improving systemic anti-cancer treatments. And we have to be always aware that this is a systemic disease, and we're all working as a team to try and get the patient better. And it's not one area of the treatment pathway that is more beneficial than the other, and they all work together. And I don't know what the optimal HIPEC agent or drug or duration is, and a lot of trials are now being designed to try and address these questions. So the future is to try and identify the optimal HIPEC regime and a better imaging to detect peritoneal malignancy more accurately. Therefore, if we can detect more accurately, we can treat it earlier. But also, we can actually monitor it and assess our treatment modalities better. For example, in Basingstoke, we've developed a diffuse weighted imaging MRI protocol, which helps our radiologists identify sometimes a disease that CTs will not pick up. PET-CT is not very good in picking peritoneal disease, in that it needs at least a 5 mm nodule for the PET detector to pick up the avidity. So you need quite a big lump before the PET scans can detect it. And again, better understanding of the biology of the tumors and identifying genes and molecular markers and predictors will probably help, again, selecting the right people who benefit most from these pretty major, well, very major operations. So now Vicki will go through a little bit about the patient journey, because at the end of the day, these are all good data and all good on paper, but there's a passion at the end of that.
There is, yeah. So one of the main things that can really help streamline the patient pathway is making sure that the referral information that we get into us is adequate for us to be able to accurately assess the patient case. So I think from your point of view, the first thing to do would be to ensure any patients coming across to us are referred to our referral team, so that the patient can be registered on our system here, and we can liaise to make sure we've got all of that right information. We hold a weekly clinical and radiological assessment meeting where we review all of the new referrals that come in a week. It's averaging about 20 to 25 referrals as a total service. So that meeting consists of a colorectal consultant, one of the CNSs, and one of the radiologists. And we will all sit and look at those referrals in the aim to respond back to the referring teams within a week, which is particularly helpful in terms of managing patients, particularly those that are unsuitable for surgery here in Basingstoke. It means that we can get them on the correct treatment pathway as quickly as possible and reduce the delay in getting information back to the referring teams. Just in terms of activity, just to give you some sort of idea, over the last 2 years, we've averaged about 400 referrals per year.
So this is for colorectal peritoneal malignancy.
We've only operated on about 100 to 120 a year, so it's quite a significant number still coming through for surgery. Almost 100% of those patients have had complete cytoreduction, and that relates back to, again, appropriate patient selection, with a 9% grade 3 or 4 post-op complication rate, and as Alex said, the immediate post-op mortality of about 1%. Yeah, so the challenges, I think, for patients are quite significant. Obviously, these patients with colorectal peritoneal metastases are at an advanced stage of their disease. They've already been through a treatment pathway of primary surgery and systemic chemotherapy for most people that we see. We take referrals from all over the country, and that has a significant impact on patients being away from home for their treatment. We are quite lucky here in that we can provide accommodation for one relative for the duration of their inpatient stay, and that's certainly something that's quite valuable for both us and the patients and the family. They're obviously facing the challenges of major surgery with all of those associated complications and the recovery duration post-operatively. There's clearly a concern about success rates and outcomes. We've looked at the data today, and I'm sure you can imagine that as a patient, that's quite terrifying to sit and to listen to, and making decisions about how you want to proceed forward. Obviously, patients are treated by multiple teams across multiple hospitals, and that creates challenges. Alone, I'm sure we've spoken to many of you. We try and build links with the local CNS teams, particularly, so that we can try and ease the pathways as best we can. Ownership of care is becoming more of a challenge, I think, as access to healthcare locally becomes more difficult, particularly with GP surgeries. We try and reassure patients that we're working together as a team, and we're certainly very happy to communicate and liaise about any patients that are being treated here or have been referred to us, so that we can give updates, so that you can certainly speak to the patients if we're not able to do so. And then just how we try and address these issues. As I said, I'm quite passionate about personalisation of patient care. It has additional challenges when patients don't live near to us, but we have over the years developed some strategies that help. We have 5 peritoneal malignancy nurses. We cover a 6-day week here, so we're able to maintain a CNS helpline for 6 out of the 7 days. What that means for us is that we maintain an open access service to patients, and that relates to last year over 5,500 patient contacts into the service. That's outside of the nurse-led telephone follow-up clinics that we do. All patients that are discharged after CRS and HIPEC are contacted by a CNS at 1 week, 6 weeks and 3 months after their discharge. I think we did over 900 follow-up calls last year. That is obviously for our total peritoneal malignancy cohort, but we don't differentiate between disease types for how we manage these patients through their surgery and their recovery. We do try to give quite detailed information packs when we meet patients in clinic, so that we can prepare them a little bit for what to expect in their treatment pathway. We ask them to take those away and read them, and again encourage them to contact us with any questions. We generally admit a day or two before the operation, depending on which hospital we're operating in, and it means that they have time to meet the very big team that's looking after them while they're in hospital. The introduction of CRAM has been published, as you can see. We introduced that in 2017, and I think that's been a definitive change in pathway management, actually, and it's been a significant improvement to the response times to referrals that come in. We use EHNAs here to try and personalise the patient care. We set those up prior to discharge, and we talk about them over the telephone and write a care plan accordingly. Just in the last 18 months, I would say we've introduced the treatment summary folders. These are treatment folders that we give to patients before they go home, and they're a multi-pocket folder, and in there we try and incorporate a complete treatment summary of their time in Basingstoke. So we include things like their clinic letter, the operation letters, discharge advice. Their EHNAs go in there, and there's room for them to add additional information, so that any patients that have been treated here should have one of those, and can show you their information just in case there's sort of a lag in things getting across to you. And then finally, every year we hold a patient wellbeing day where we invite probably about 100 patients a year attend. We go to a local hotel and we have a day of talks and networking for patients, and we have a big Q&A multidisciplinary panel session. The consultants do talks for us. We have research updates, and yeah, that's free to attend, and we advertise that to patients on an annual basis. It's usually in about June time, I think. Yeah, I think. In summary.
So in summary, we did cover quite a lot, and probably maybe too much. The key message, I guess, is that colorectal peritoneal metastasis is a systemic process, and treatment is not just surgical. It's multimodality. Good quality of surgery, along with HIPEC, does improve outcomes, but only in the selected patients. And unfortunately is not good enough to be able to deal with every patient. We still have a lot of unanswered questions about when we should do surgery, what the role of the HIPEC is, and what agent to use and how to use it. And then from the patient point of view, this is a complex treatment pathway, and it does involve a lot of healthcare professionals, a lot of different hospitals, different sites of treatment areas, and it can be quite overwhelming, which is why effective and clear communication between anyone who's involved in their care is probably essential, and we're trying to focus on that. And that's all we have.
Thank you.
Oh, thank you so much. And you didn't cover too much at all. It was absolutely fascinating. It was really interesting to hear the trials, particularly, and the results. And you've got some really good results that happening in Basingstoke, which is great and really encouraging, because when you refer patients down, you're always, it's so good to see that data before you refer. Not that we wouldn't refer our patients, but just to see that is great. So thank you so much.
I have to stress here that our data is very comparable to Manchester and Birmingham. You know, we're not just amazing here. Our colleagues in Manchester also doing a very good job, and in Birmingham and in Dundee, and of course in Dublin. And we work together. We talk to each other a lot.
Yeah, you have fantastic busy services, and it really shows the volume of work that you put through, because the outcomes improve, don't they, with that, I think. And we've got a few questions, if that's okay. We're a little bit over time, so I won't. So a couple about side effects. The side effects from HIPEC with oxaliplatin compared to when it's given IV was one question, and the difference in side effects between the two HIPEC chemotherapies.
So the Prodigy 7 was reporting in general postoperative complications. So I don't know if everyone is familiar with Clavendin classification. Basically, it's 4 classes. If whatever complication you have only needed drugs, then it's class 1 or 2, and if it involves intervention that requires a general anesthetic or interventional radiology, it becomes a 3, or if it needs ITU support, then it becomes a 4, and then if the patient dies, then it's a 5. So so the report is surgical complications, not specific to the HIPEC. In general, oxaliplatin tends to cause more bleeding, and in theory it shouldn't be absorbed into this bloodstream. So HIPEC is supposed to penetrate about 1 to 2 millimeters into the tissues. Obviously, a little bit of drug will be in the bloodstream, but it shouldn't be enough to cause you systemic complications. And from mitomycin point of view, we've had 2 or 3 people with rashes, which resolved after 24 hours, and we've had 3 or 4 where the platelets dropped. We're not sure whether that was because they had a 14-hour operation and they've lost 2 liters of blood, or whether it was the mitomycin. We, being surgeons, blamed on the mitomycin.
Okay, thank you. That's really helpful. We've got a surveillance question as well. So it says, for patients who are post surgery and HIPEC, is for Basingstoke protocol follow-up locally, would you prefer to get a copy of their surveillance scans and tumour markers every time they're done? Or should we just make a referral back to Basingstoke only if the results have worrying findings? And that is tricky. We worry about particularly the radiology.
So there's there's one answer, is that yes, we don't want to know, because obviously we've spent a lot of effort and time to look after these patients. So from our point of view, we would like to know whether we've done them any good. We would not necessarily review, our radiologists would not review the scans unless there is concern by the local radiologist. But we would like to know, as surgeons, we like to hear whether the scan is okay or not. So it's just that, for example, for appendix tumors, we review the scans because it's a more specialist area. And I have to say that the quality of the radiology reports is improving almost every few months. So generally, very rarely our radiologists will pick up something that a local radiologist might have missed. But we would like to know. We do like to know, because it also helps us then monitor our data, and then we can then tell you that the data we told you is accurate. It's not made up. It's not like it's our impression, because obviously the data any database is as good as the data you put in the database.
Yeah. So for us to let you know the outcomes, but only get the scans reviewed if we think there's disease present and we need it to be reviewed. Okay, thank you. And just a final question for you, Vicki, if I could. Just to say, what are the main challenges you would say patients experience in their first few weeks at home after discharge?
Mostly fatigue. I would say fatigue is the biggest thing. And so we talk to them a lot about setting realistic goals, making sure that they build regular rest periods into their day, that they're eating little and often, staying mobile enough so that they reduce the risk of post-op complications of, clots and infections and things. But it's mostly fatigue, I would say, is the biggest problem. That and bowel function. Yeah, we talk a lot about bowel function, as I'm sure you all do.
Yeah, okay. Yeah, that's really useful to know. For us as specialist nurses working in places where patients are discharged, to keep regular contact, do the usual assessments of bowel function, and real encouragement about managing a cycle of fatigue, isn't it?
It is, and I normally tell patients that first 4 to 6 weeks after they go home is probably the hardest part, because they recover so quickly from theatre to discharge, so that they're well enough to look after themselves at home and manage. And then that really slows down, and that gets really frustrating, because that's the point where they're at home, they're frustrated, they wonder whether they've done the right thing, where they're behind them saying it's going to get better, it's going to get better. They don't think it is going to get better. It can be quite hard, on family relations. We know that quite a lot of people struggle with that, because it is a long period of recovery. So I think that's fatigue and bowels, I would say, are definitely the most common things that we talk about.
Thank you very much. Thank you both. I could keep asking you questions. Oh, I think there is one more. Let me just see but I will stop. I'll just say, so it's a comment. It was interesting to hear about the treatment summary folder. So that they haven't seen it. So we'll have to I think that's a note for us, the CNS, to ask, can we see it?
Yeah, they're a big A4 blue plastic folder. You can't miss it. Big folder with lots of information and contact details and things in it.
Thank you both so much. We've really enjoyed having you with us, and we hope that the talk has been valuable.